Think about building a house. You pour the foundation, frame out the walls, put in all the plumbing.
Right, and that plumbing is basically a fixed blueprint. The pipes go where they go.
Exactly. And that's that. But imagine if the entire plumbing system of that house had to completely reroute itself, like flawlessly, the exact second you turn the key in the front door.
I mean, you'd expect massive leaks, burst pipes, just total system failure. The physics of changing a high-pressure fluid dynamic system while it's actively running it basically defies standard engineering principles.
But that is the precise engineering miracle that your own heart had to execute the exact moment you took your first breath. Welcome to the Deep Dive. Today we are taking you on a journey into hearts built differently.
It's a fascinating topic.
It really is. Our mission today is to take an accessible but really rigorous look into the pathophysiology of congenital heart defects, or CHD. We're going to explore how structural deviations alter the body's circulation right from birth.
Yeah, and we'll look at the pioneers who mapped out this totally uncharted territory.
Plus, the surprising reason why a heart defect might actually just mean your biological software missed a critical update. Okay, let's unpack this. What exactly constitutes a congenital heart defect? Structurally speaking, we're looking at abnormalities of the heart, or the great vessels that arise during this remarkably tiny window, roughly the first 8 weeks of cardiac embryogenesis.
And right out of the gate here, we really need to correct a persistent assumption that kind of shadows this whole topic. The word congenital simply means present at birth. It does not automatically mean genetic.
Which is a huge distinction.
It is paramount. The two terms get conflated constantly in public discourse. But while a CHD can occasionally stem from, say, a single gene mutation, a chromosomal anomaly, maternal infections, or pharmacological exposure, the vast majority of cases, we're talking approximately 80%, have no identifiable etiology at all.
Wait, 80%? There's no known cause.
Exactly. It's not inherited in those cases. It is simply a statistical reality of biological construction.
That framing completely shifts the narrative. I mean, it shifts the entire burden of guilt away from parents who often assume they did something wrong during pregnancy.
It really does. It emphasizes that building a human heart from scratch is just this incredibly precarious feat of cellular origami.
Cellular origami, I like that. Which means before we can analyze how the structure fails or, folds incorrectly, we had to map the original blueprint. Because the circulatory system of a fetus operates under an entirely different set of physical laws than yours or mine.
Right. The physical environment dictates the plumbing. So around day 22 of gestation, the heart is essentially this single, simple tube that just begins looping and folding upon itself.
Just a single tube.
Yeah. And over the subsequent 6 weeks, internal walls, which we call septa, grow to divide that tube into 4 distinct chambers. Concurrently, the single massive embryonic vessel leaving the heart, it spirals and cleaves into 2 distinct pipes, the aorta and the pulmonary artery.
And so nearly every structural defect originates in this super narrow 6-week corridor.
Pretty much. A septal wall halts its growth prematurely, a vessel fails to divide fully, or maybe a valve forms with irregular leaflets.
I want to push back on a conceptual trap here, though, because it's really easy for us to visualize a fetal heart as just a miniature, in-progress adult heart, like it's just doing dry runs until delivery day. But the sources highlight that it's an entirely distinct hemodynamic system. I mean, a fetus is submerged in amniotic fluid.
Exactly. They're basically underwater.
Right. So the lungs aren't processing air. Oxygen delivery is entirely outsourced to the mother via the placenta.
That is the critical variable. Because those fetal lungs are essentially collapsed and filled with fluid, the pulmonary vascular resistance is incredibly high. It takes immense pressure to force blood into them.
And there's no point anyway, right?
Exactly. Frankly, there is no biological utility in sending the bulk of the cardiac output there, since they aren't oxygenating anything yet. So fetal circulation utilizes 3 highly specific shunts to strategically bypass the lungs and the liver.
Okay, the foramen ovale, the ductus arteriosus, and the ductus venosus.
Precisely. So the foramen oval is a literal flat valve hole between the upper chambers, the atria,
Just a trapdoor?
pretty much. Then the ductus arteriosus is a bridging vessel that shuttles blood from the pulmonary artery directly over to the aorta, completely skipping the lungs, and the ductus venosus bypasses the liver.
So these aren't flaws at all.
No, they are absolute survival mechanisms,
Yeah.
and they are biologically programmed to detect the profound chemical and pressure shifts of a baby's first breath, which prompts them to mechanically clamp shut in the hours or weeks following birth.
So tying this back to our house plumbing analogy for the listener, conditions like a patent foramen oval, a PFO, or a patent ductus arteriosus, a PDA, those aren't bizarre alien mutations. And patent just means open, right?
Yes, patent just means open.
So it's like a construction crew that installed a vital bypass valve during the house build, but simply missed the biological cue to close it when the main water line finally turned on. It is perfectly normal fetal anatomy operating in the wrong developmental era.
What's fascinating here is how this entirely reframes our clinical definition of a defect. In the context of these patent shunts, the anatomical structure itself is flawless. The error is strictly chronological.
Wow. But when that chronological error occurs, or when that 6-week cellular origami folds incorrectly, the resulting structural variations permanently warp how blood navigates the body. And the most prevalent variations are exactly what you'd expect when walls fail to fuse. Holes.
Right, specifically septal defects.
Yeah.
The ventricular septal defect, or VSD, accounts for roughly 30 to 40% of all congenital heart anomalies. This is a deficiency in the muscular or membranous wall separating the heart's main lower pumping chambers.
And to appreciate why a VSD is so consequential, we have to look at the pressure gradients. I mean, the left ventricle is the heavy lifter, right?
Oh, absolutely.
It's generating enough systemic pressure to push blood all the way to the top of your head and the tips of your toes. But the right ventricle only has to push blood right next door to the lungs, so it operates at a fraction of that pressure.
So if there is a hole between them, basic fluid dynamics dictates that blood will take the path of least resistance.
Which creates a left-to-right shunt.
Exactly. Every single time the heart contracts, highly pressurized, newly oxygenated blood in the left ventricle gets ejected backward through that defect right into the low-pressure right ventricle.
That sounds exhausting for the heart.
The hemodynamic penalty is severe. The heart endlessly recirculates already oxygenated blood back through the pulmonary circuit. The left side has to pump exponentially larger volumes just to maintain normal systemic output. It is a highly inefficient volume loading loop.
Then you have obstructive lesions where the plumbing is physically bottlenecked. The classic example in the literature is coarctation of the aorta. It's a severe narrowing in the main arterial highway leaving the heart.
And the diagnostic presentation of this is just fascinating because it's pure mechanical logic.
This is the classic medical student diagnostic gift, right?
Yeah. Yes. The narrowing typically occurs just distal to or just past the arterial branches that supply the brain and the arms. So if you examine an infant with this condition, they present with bounding pulses and high blood pressure in their upper body.
But weak, delayed pulses in their legs.
Exactly. It's a physical manifestation of a localized traffic jam.
It is an elegant, if troubling, demonstration of fluid mechanics. But the pathophysiology escalates drastically when we examine complex cyanotic lesions, defects that fundamentally deprive the systemic circulation of oxygen, literally turning the patient's skin and mucous membranes blue.
Right, the blue baby syndrome. Congenital transposition of the great arteries. We discussed how that single embryonic trunk is supposed to spiral as it divides, right?
Right. But in transposition, the trunk divides, but the spiraling mechanism fails.
Consequently, the major output vessels are wired to the entirely wrong chambers. The aorta connects to the right ventricle, and the pulmonary artery connects to the left.
That's terrifying.
You are left with two parallel, completely isolated circulatory loops. The right heart pumps deoxygenated blood to the body, which returns deoxygenated. The left heart pumps oxygenated blood to the lungs, which returns to the lungs. They never cross paths.
This raises an important question. How does a newborn survive even a few minutes with a circulatory system that explicitly isolates oxygen from the brain and body?
They survive strictly by relying on another defect.
Wait, really? Two wrongs make a right.
In this case, yes. If those parallel loops do not have a cross-communication point like a concurrent VSD or a patent foramen oval, the condition is rapidly fatal. The baby needs a hole to allow those separate circuits to mix.
And recognizing this biological necessity led to a brilliant intervention, right? In 1966 by Dr. William Rashkind.
Yes, the Rashkin balloon septostomy. He engineered a catheter procedure to thread a balloon into the infant's heart, inflate it, and aggressively pull it back to intentionally tear a hole in the atrial septum.
Intentionally tearing a hole in the heart.
This manufactured defect allowed the blood to mix, serving as this desperate physiological bridge until surgeons could formally go in and switch the vessels.
Here's where it gets really interesting. We've talked about pipes crossing and walls failing to close, but what about when a crucial component of the architecture just doesn't develop at all?
Single ventricle physiology.
Yes, the sources highlight single ventricle physiology with hypoplastic left heart syndrome, or HLHS being a prime example. Hypoplastic basically meaning severely underdeveloped.
In HLHS, the entire left ventricle, which is the chamber responsible for sustaining the body's entire systemic circulation, is essentially a non-functional nub. The baby is born with half a functioning heart.
The clinical reality of HLHS in the mid-20th century was grim. It was universally fatal. And the path to addressing something that complex didn't start in the operating room, did it?
No, it started in the morgue. For centuries, these complex structural variations were completely invisible in living patients. The foundational taxonomy of this field was established by Maud Abbott, a pioneering Canadian physician at McGill University.
And Abbott's story is incredible because she was formally barred from clinical medical practice at her institution purely because of her gender.
Banned from the wards. So she redirected her intellect into pathology. She meticulously cataloged over 1,000 preserved cardiac specimens, and in 1936 she published the Atlas of Congenital Cardiac Disease.
She didn't just list anomalies either.
Right. She categorized them based on their hemodynamic consequences, whether they caused cyanosis, how they altered flow. She essentially handed the medical community the first comprehensive schematic of congenital pathology.
And you can't fix a machine if you don't have a schematic. Abbott's taxonomy transformed these isolated, confusing clinical observations into a shared scientific language. And that shared language was the catalyst for physicians who were basically forced to attempt the impossible, watching infants with cyanotic defects succumb to oxygen deprivation.
Which takes us to Johns Hopkins in 1944.
Yes, Helen Taussig, a pediatric cardiologist who was accurately diagnosing these blue babies with tetralogy of Fallot, but she lacked any therapeutic options. He approached an elite surgeon, Alfred Blalock, with a radical idea to surgically construct a shunt to increase pulmonary blood flow.
But the execution of that idea hinged entirely on Blalock's surgical research technician, Vivian Thomas.
The historical context of Vivian Thomas is staggering. Thomas was a black surgical researcher operating in the deeply segregated era of the 1940s. He was denied access to medical school, formally classified and paid as a janitor, but he was nonetheless the intellectual and technical engine of Blalock's laboratory.
He was a genius. Thomas spent months designing the surgical tools and perfecting the delicate vascular anastomosis on canine models.
And when it came time for the unprecedented human trial on a fragile 15-month-old named Eileen Saxon, Thomas was not allowed to scrub in.
Because of his race.
Exactly. He had to stand on a step stool behind Blalock, verbally guiding the chief surgeon step by step through the procedure that Thomas himself had invented.
It's a heavy legacy. But the result was the Blalock-Taussig shunt. They successfully rerouted a systemic artery into the pulmonary circulation. Eileen Saxon's cyanosis resolved. She turned pink right there on the operating table.
Unbelievable.
That single procedure catalyzed the entire modern discipline of pediatric cardiovascular surgery. It proved that structural fatalism could be surgically challenged.
But the dawn of surgical intervention also exposed a ruthless physiological deadline. Surgeons quickly learned that structural anomalies trigger a cascading chain of damage. You cannot just, wait and see and let an infant grow larger before operating.
No, the paramount example of this ticking clock is Eisenmenger syndrome. Let's revisit the ventricular septal defect, the hole driving high-pressure blood back into the lungs.
Okay, the left to right shunt.
Right. The pulmonary vascular bed is incredibly delicate. It is not designed to absorb systemic pressure. If that left to right shunt is left uncorrected, the sheer force and volume of the extra blood shear the lining of the pulmonary arterioles. Over years, these vessels protect themselves by thickening, scarring, and becoming rigid.
And as those vessels scar, the resistance in the lungs skyrockets.
Exactly. The pulmonary resistance climbs so high that the pressure in the right side of the heart eventually eclipses the pressure in the left. And in that moment, fluid dynamics reverse.
The flow flips.
It flips. Oxygen-depleted blood from the right ventricle is now forced into the left ventricle and pumped out to the body. The patient turns profoundly blue. Once the shunt reverses, closing the septal hole is no longer an option because if you plug the hole, the right ventricle will immediately fail trying to pump against those irreversibly scarred lungs.
It's the physiological equivalent of a leaky dam. Water constantly pushing backward into a fragile secondary reservoir will hold for a time, but the relentless back pressure eventually degrades the reservoir walls. Once the reservoir system is destroyed, plugging the initial leak doesn't solve the crisis. The secondary damage is irreversible. Timing the intervention before the pulmonary vascular bed remodels is everything.
And that urgency drove surgical innovation toward extreme, staged palliations, especially for single ventricle anomalies like HLHS. In the 1980s, Dr. William Norwood conceptualized a three-stage sequence of open-heart surgeries designed to replumb the infant's entire circulation.
3 open-heart procedures on an infant, just to configure a working system out of half a heart.
And the final stage of that sequence, known as the Fontan procedure, represents the zenith of hemodynamic audacity. Because there's no right ventricle to pump deoxygenated blood to the lungs, surgeons detach the major veins returning blood from the body, the vena cava, and connect them directly to the pulmonary arteries.
Wait, so systemic venous return flows straight into the lungs without any pump driving it?
None. The solitary working ventricle is exclusively dedicated to pumping oxygenated blood out to the body. The return trip through the lungs relies entirely on passive pressure gradients.
Passive? How does that even work?
When the patient breathes in, the diaphragm drops, creating negative intrathoracic pressure. It's a vacuum effect that literally pulls venous blood up from the body and draws it passively through the pulmonary capillaries.
That is wild.
If we connect this to the bigger picture, the Fontan procedure fundamentally alters how we categorize medical intervention. The sequence does not cure hypoplastic left heart syndrome. The original anatomical deficit remains. Instead, it aggressively palliates it, creating a highly customized, wholly non-standard circulatory system that requires intensive, lifelong maintenance.
And the widespread success of these non-standard engineered circulatory systems has triggered a massive paradigm shift in the demographics of congenital heart disease. But to appreciate that shift, we first need to dismantle the persistent myth that a baby born with a significant cardiac defect will look visibly ill or cyanotic in the delivery room.
That assumption is super dangerous because so many of these defects are entirely silent at birth. The baby presents as pink, vigorous, and perfectly healthy.
Historically, this silence led to profound tragedies, but it also spurred major public health evolutions. Like in 1941, Norman Gregg, an Australian ophthalmologist, connected an unusual cluster of infants born with cataracts and silent heart anomalies to mothers who had contracted rubella German measles during early pregnancy.
Gregg's observation proved that maternal viral pathogens could traverse the placenta and actively disrupt early cardiac embryogenesis. It established an environmental etiology for structural defects and became a cornerstone argument for the eventual global deployment of the rubella vaccine.
Yet, even with vaccines and advanced prenatal ultrasounds, a dangerous gap remained. An infant could pass their newborn physical, be discharged, and suddenly go into shock at home a few days later.
Because of the ductus arteriosus.
Exactly. A ductal-dependent lesion, like a severe coarctation, was being temporarily masked by that fetal shunt we talked about earlier. When the shunt naturally clamped shut at home, it severed the baby's only compensatory lifeline. This specific vulnerability ignited a fierce, years-long debate in the medical community over implementing universal pulse oximetry screening for newborns.
Pulse oximetry is a non-invasive tool, just a simple light sensor placed on the infant's hand and foot to measure oxygen saturation. The debate wasn't about the technology's safety, but its systemic impact.
Because it's about resources.
Right. Critics pointed out that applying this to millions of births would generate thousands of false positives due to harmless transition murmurs or minor respiratory issues. This would mandate expensive, stressful echocardiograms, overwhelming pediatric cardiology resources, and terrifying new parents unnecessarily.
But advocates countered that the cost of an echocardiogram paled in comparison to the catastrophic outcome of sending an infant home to die from a silent structural anomaly. They argued that catching even a fraction of those hidden defects before discharge justified the logistical burden. And the data ultimately validated the advocates. The screening reliably flagged anomalies that slipped past prenatal imaging, and it was officially added to the U.S. recommended uniform screening panel in 2011.
It was a triumph of preventative public health. But the culmination of aggressive screening coupled with the surgical miracles pioneered by figures like Norwood and Blaylock, has manifested a demographic reality that borders on science fiction. Today, because pediatric survival rates have skyrocketed, there are more adults living with congenital heart disease than
I
children.
want to make sure you, the listener, catch the weight of that. The medical field got so incredibly proficient at saving infants that they engineered a patient population that literally did not exist in significant numbers a generation ago.
The clinical infrastructure is currently racing to adapt to this. We are now establishing specialized adult congenital heart disease, or ACHD centers. These clinicians are tasked with managing the long-term consequences of non-standard plumbing 50-year-old Fontan circulations, aging shunts, and complex arrhythmias in a population charting entirely new physiological territory.
So what does this all mean?
It means our definition of normal biology is being tested by our technological capabilities. With the advent of ultra-high-resolution imaging, we are identifying structural variations that would have gone completely unnoticed decades ago. Take the bicuspid aortic valve, where the valve forms with 2 leaflets instead of the usual 3. We now recognize this variant in 1 to 2% of the general population.
Statistically, that means you likely know someone, or perhaps you yourself have a bicuspid valve and might remain asymptomatic for 5 or 6 decades.
Exactly, which forces the clinical community to ask, is that a defect requiring monitoring or simply a benign structural variant? Conversely, our imaging now allows us to observe these deviations in utero, driving the bleeding edge of fetal intervention.
Oh, wow. Fetal interventions.
Yeah, specialists are currently debating the efficacy of threading catheters into the hearts of fetuses still in the womb, attempting to force open tightly narrowed valves to prevent the secondary development of conditions like HLHS before the baby is even born.
Presenting incredible technical achievements alongside massive ethical and evidence-based debates. The field is just constantly pushing the boundaries of when and how we intervene in natural development. It has been a really profound journey today.
It really has.
We traced the cascade of cardiac embryogenesis, marveling at how a simple folding tube transitions into a 4-chambered pump. We mapped the ingenious fetal shunts, explored Maud Abbott's foundational taxonomy, and honored the indispensable genius of Vivian Thomas in the 1940s. We've seen how interventions evolved from desperate surgical shunts to the hemodynamic marvel of passive venous flow, resulting in an unprecedented generation of adults thriving with brilliantly re-engineered biology.
It underscores that the human circulatory system is far more adaptable than just a static set of rigid pipes. It is a dynamic, resilient network, constantly compensating and reacting to the pressures placed upon it.
Thank you for joining us on this deep dive into how our hearts are built differently. Understanding the physiological how and why illuminates the sheer resilience of the human body. But before we sign off, I want to leave you with a thought to mull over.
It's a good one.
As our diagnostic lenses become microscopically precise, we are finding tiny, silent anomalies, a millimeter-wide PFO, or a subtle valve variation that may never impact a person's lifespan or capability. If the blueprint of a house has a pipe shifted a fraction of an inch, but the water runs flawlessly for 80 years, at what point do we stop labeling these variations as medical defects to be monitored and start accepting them as just another beautiful natural variation in how human beings are built?
As technology outpaces our traditional categories, that is the defining question for the next era of cardiology.
Until next time.